Dr. Maunika, Regional Medical Advisor from Shield Healthcare. I welcome you all for today's session, Trending as A to Z series, which is conducted by AGOG, Academia of Global Obstetrics and Gynecology. And today, we are going to discuss about episode Q, which is Quality and Dignity in Maternity Care. I welcome you all for today's episode. And with this, we'll be starting our session with a small prayer.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
I welcome our coordinators. Dr. Dinesh Wade is an MBBS, MS, DNB, MRCOG UK and FNB Reproductive Medicine. Is a consultant gynecologist and IVF specialist, mentor for MRCOG infertility high-risk obstetrics courses at Study Medic. And Dr. Hitendrasingh Rajput, MBBS, MS, OBGYN and DNB consultant obstetrician and gynecologist, Aurangabad. I welcome you both and I hand over the session to Dr. Dinesh sir.
Thank you, Doctor, for a lovely introduction. So yes, myself, Dr. Dinesh, and I welcome all the wonderful ladies and gentlemen for this wonderful evening for the session on the Q series. As we know that we learn A, B, C, D to learn something new in our life, to develop and to gain more knowledge. And that's the reason in the field of obstetrics, the first time this alphabet has come up with a series of A, B, C, D. And today we are into the chapter of Q, Quality and Dignity in Maternal Care. Maternal care, it is one of the things that every obstetrician struggles from the day one of their residency. Each and every organization fights to get a good maternal care. Every mother dreams for the safe motherhood. And I'm very honored that the FOXY has done so many steps and evolved so ahead of the time with such a dignitaries that now we are approaching towards what exactly a good maternal care. And today this session is basically to sum up whatever we have done so far and what are our visions and aims with the help of our seniors. So let me to start this session by introducing one of the two magnificent personalities in my life to introduce our convener, Dr. Komal Chavan ma'am. She is the medical director of Chavan Maternity and Nursing and the DNB teachers and unit chair in BM Desai Hospital, honorary professor in Cooper Hospital. She was the FOXY Medical Disorder Pregnancy Chairperson and being very honored that the committee has won the Best Committee Award and Zonal Coordinator for the FOXY. So there are the many more things about ma'ams to talk and everyone knows about madam very well. Talking about our co-convener, Dr. Niranjan Chavan sir, one of the efficient personality which illuminates the life of all the residents and make them aware about what exactly the obstetrics. So may I have the slides of Niranjan Chavan sir. So Niranjan sir is a unit head in the Sion Hospital and yes, he is being a part of FOXY and yes, sir is the president of MOGS and sir's magnificent era is like all are very well aware about sir enthusiasm. He's a member of Oncology Committee, Joint Secretary of AFG. He has many more publications, 64 publication international and national, also to be very honored that he's the editorial board of European Journal of Gynae and Oncology. So yes, under the guidance, yes, all the budding obstetricians going ahead. So I welcome both of you and let's handing over to Komal ma'am.
Thank you so much, Dr. Dinesh, for the kind introduction. And I welcome you all for this Trending Ask the Expert series along with AGOG. And today's episode is Q, and Q stands for Quality and Dignity in Maternal Health. And when we talk about quality, we know that the health across India needs to be standardized, and we need to give quality care to our mothers. Maternal health is a reflection of the health of the entire nation. That is very, very important, that we obstetricians give them good health. We don't want to have any morbidity or any mortality, both maternal as well as neonatal. And dignity is very important. Dignity is how we treat the mother while she is in labor, because the pregnancy period and the delivery is a very different experience, and the mother is going to remember how she is being treated, how she is being spoken about, how the care was taken for her entire life. The way the obstetrician has come to her, spoken to her, the treatment given to her. So I think that is very important, that we improve and we go for this quality and dignity in maternal health. And for that, we have very eminent speakers, Dr. Hema Divakar, who is the key wherein Foxy's initiative Manyata is doing so much on this topic. So Dr. Hema Divakar, our very own past president of Foxy, is going to be one of the speakers, along with Dr. Ameya Purandare will be there. And we have galaxy of chairpersons who are really there for the cause. And I am very honored that today, Secretary General of Foxy, Dr. Madhuri Patel, is a chief guest, and Dr. Anita Singh and Manju Shukla as the guest of honor. And formally to introduce Dr. Madhuri Patel, we know she is the first lady Secretary General of Foxy and is currently also on the FIGO committee of preterm birth, Associate Editor of Journal of Obstetrics and Gynecology of India, Honorary Clinical Associate at Nauroji Wadia Hospital, Parel, Honorary Consultant at Police Hospital, Visiting Consultant, St. Elizabeth Masina Hospital. She's a teacher par excellence. She's received the Shailaja Pandit Narayan Pandit Award from MOGS, and she is really very supportive whenever we call her. She is always guiding, helping, and very soft-spoken and very humble. I think we have to imbibe so many qualities from her. So I request Madhuri Patel, Madam, to kindly address our audience.
Thank you, Komal, for your kind and warm words. Respected our guest of honor, Madam Anita Singh. She is at present president of Bihar Jharkhand State, and I had been there for her installation, and we had worked together when she was a vice president of Foxy, and we are really working towards reduction in maternal mortality rate. And of course, I cannot say anything about Madam Manju Shukla. She is an inspiration to me. I always admire her, and she is always supportive. Whenever I go, wherever we go, we are so happy to see each other. And of course, she is the another queen of Lucknow. I will definitely say that. Then we have of course, Komal as a convener and the speaker. She has really worked hard. I've seen her working hard during her, chairperson post as a medical disorder of, pregnancy. And really, it was a great year she had worked. Then, of course, Niranjan, I cannot say anything to him, but I must say that as an MOGS president, he has done fantastic work. And now he is my joint treasurer. So whenever I said, Niranjan, you keep quiet, he will keep quiet, But as an MOGS president, I could not tell him anything, but he is very respectable and he is doing a great work. Then, of course, Dr. Hema Divakar, our past president of Foxy, and of course, she is the director, coordinator, whatever you say, when we started our Manyata program. And, now it has gone to a, very, very, long way, and we want to take it further. Ameya and Rishikesh Pai are also, coordinator and co-coordinator, and we have involved now, almost 22 states, Ameya. And, there are more than 1,800, centers, facilities are, certified. The idea is that Foxy, we have so many facilities, private sector, because the 45% of the private sector, they deliver our ladies and, women, and, others are in the government. So whatever facilities are available from the government side, they are most of the time from the government sector. So these are the facilities which we have put in Manyata, which is a flagship program. It is really giving us a result, because we are not training only obstetrician, but we are also training the paramedical staff. And remember, these paramedical staffs are our backbone. So, as an obstetrician, I'll go and see the patient and when required. But in an emergency, these people are the ones who are going to tell us that this is the problem, please come down. And then we are going to manage. So it is very important. So our Manyata program of Foxy, we are doing fantastic. And secondly, we are also having many, donors, especially FIGO. And, FIGO, we have done a PPH program and they are concentrating more on our state like UP, Bihar and all, where the maternal mortality rate is high. And so most common cause is postpartum hemorrhage. And they are concentrating to, postpartum hemorrhage, what to give about tranexamic acid, bundle branch, first hour, golden hour, you should not waste. And what are they? So they are more concentrating on, UP and Bihar, where the maternal mortality rate is high, where the PPH is a major cause of maternal mortality. So, as in, we are also having a leadership program from FIGO. Again, we are going to deal with the UP and Bihar, where PPH is really, and the anemia are the most common causes of maternal mortality. And therefore, we want to reduce our maternal mortality rate. As a Foxy Secretary General, I would like to say that we have many missions, but one of the mission is reduction in maternal mortality rate. And we are just walking towards our sustainable development goal of maternal mortality rate reduction less than 70 per 100,000 live birth. And I'm happy to say that we have achieved at present 97 per 100,000 live birth. And I'm very happy to share that Kerala is at the top. And I would like to talk about the Maharashtra. Then we could reduce the Maharashtra maternal mortality rate to 33 per 100,000 live birth. And the reason is that 99% are institutional delivery. We could improve the infrastructure and we could hire more specialists in form of obstetrician and gynecology. And the other state where the maternal mortality rate are high, I have already mentioned. The other reason is that there are home deliveries. So these home deliveries, if we can convert into institutional delivery, then we can reduce our maternal mortality very, very low, maybe, 30, 40, like that in very near future. So from Foxy, we are really working hard. Our Safe Motherhood Committee, our Practical Obstetric Committee, and all our agenda is towards the maternal mortality rate reduction. And of course, we have also included in our mission about the preventive oncology, because we realize there is a 30, 60, 90 problem. We could reduce the maternal mortality rate, but still our 30,000 women are dying per year and 60,000 women are dying because of the cancer cervix and 90,000 are dying because of the breast cancer. So we have also included our mission that preventive oncology and elimination of the cervical cancer. So we have so many vibrant society, 266, all are doing fantastic work, and our 40,000 plus members, they are really committed to women's health, and all our committee chair, I'm really appreciating that. And I'm really, for this, webinar, as Dr. Dinesh has said, we have come to now Q, right? A to Z, we are at Q, and this is a quality and dignity of the maternal care. This is also one of the reasons when you give good maternal dignity as well as the maternal care, it will again going to reduce the maternal mortality rate. And respect to maternal care is very important on that point. Then more and more mother, if you respect them, more and more women are going to have a delivery in the institution. That is also going to reduce the maternal mortality rate. Apart from our standard, this is definitely going to have. And I wish Niranjan, Komal, Dinesh, and all other people best luck for this webinar. Thank you very much for inviting me as a chief guest for this program. Thank you very much.
Thank you. Thank you so much, madam. I think you have put another insight into the work, really, with the leadership of you and Dr. Rishikesh Pai. Foxy is doing fantastic work, and it becomes our also individual responsibility to do our best to improve the quality and dignity in maternal care. And we all are there in this Foxy's goal and mission. We stand united for it. Thank you so much, madam, for your pearls of wisdom. And now I call upon Dr. Anita Singh. our guest of honor. And we know Anita Singh has been the state leader from Jharkhand and Bihar. Madam already said that she has been recently installed. She's also been the past vice president of Foxy, and I had an opportunity to work during her tenure as a chairperson. And she is the ex-professor of Patna Medical College, chairperson endocrinology committee of Foxy, then member governing council of ICOG. She's organized various conferences and contributed to many books, chapters, and national journals. So over to you, Dr. Anita Singh ji. Please address the audience.
Thank you, Dr. Komal, for such a nice introduction. And it was so good listening to our Secretary General, Dr. Madhuri Patel. She is so much concerned about the women's healthcare in our country. And as a Secretary General, she is in a position to do quite a lot of things, what she's trying to do. And I hope that in the leadership of Foxy, we'll be able to reach the SDG goal even before that. And our lamppost doesn't seem to be very far away now. And so far as today's CME is concerned, I wish to congratulate at the beginning itself, Niranjan and Komal. They are working hard towards this series of CMEs. And both of them I know personally, and I'm quite friendly to Dr. Niranjan. I know how much he's sincere towards his responsibilities and duties, whatever is bestowed upon him. And regarding the other guest of honor, Dr. Manju Shukla, I welcome you, madam, the evergreen star of Foxy. You are always there smiling and taking participation in most of the activities of Foxy. Regarding the topic today, it has been talked quite a lot now. And this quality care is actually the word which has been coined very well, because we are all giving, from medical point of view, a good care to the antenatal and internatal patients. But so far as we should be very careful towards the quality, what sort of quality, not only regarding the academics, but also regarding the behavior. What sort of respectful maternity care is being taken up at any institution. We should be very careful about it, and it is the duty of the chief to be careful about this all the time, so that there are no lapses in the management of the patient. So today's topics have been chosen very well. And regarding the speakers, we have got the star speaker, Dr. Hema Divakar, with us. She's going to talk about a lot about the Manyata, and we have all got registered our institutions under Manyata. And whoever has gone through it knows how effective and necessary it is to have all the, even the smaller maternity centers get registered under Manyata and get a certification from Manyata, which is so helpful in improving the standards of obstetric care. So and the other two speakers, Dr. Ameya and Dr. Komal, they are very good orators, I know, and they have been given a very important topics for today's CME. And I wish they are going to do justice to the topic. And I also wish good luck to this CME and a great success, and keep on, Komal, keep on doing all these programs in the future also, you and Niranjan. Thank you very much for calling me as a guest of honor for this program. Thank you.
Thank you. Thank you so much, madam. It was such lovely words from you. Are so inspiring always. Thank you. Thank you for gracing the occasion with your esteemed presence. And now I call upon our another guest of honor, Dr. Manju Shukla ji. Dr. Manju Shukla, I think rightly said by Anita Singh, madam, she's an evergreen, and today she is in green. So she's always so charming and so nice. You know, I think she is the most loved person from Lucknow. So she's a retired professor at KGMU Medical College, Lucknow, president of UPCOG, president of Lucknow OBGYN Society, chief editor of Journal of UPCOG, and she has been master trainer for so many maternal issues like contraception, EMOC, maternal health, you know, quality awareness, national assessor in quality Lakshya projects. So I think this all is her forte, and I think she does it so effortlessly with a very, very nice smile, ever smiling, ever loving, and always so encouraging. So over to you, Dr. Manju Shukla, madam. आप आए प्रोग्राम में, चार चांद आई और बाहर आ गए, मैडम. Over to you.
Thank you, Komal, for such a nice word. So, बापरे, मैं तो I can never think of Queen of Lucknow and all. but nice introduction. Thank you very much for inviting me as guest of honor. I am very proud. I'm feeling very proud that you have invited me. And the quality is my passion. You know, I am quality assessor and I'm assessing all labor rooms in all over India. Government hospital, labor room, OT and everything to provide quality care to mother and baby. And in this era of litigation, quality care is very, very important. And lot has been taught by Manyata, Dr. Hema Divakar. She is the pioneer, I think, in maternal care, health care, providing quality service. And nowadays, it is a policy of government also to post one quality manager in all district hospitals, CHCs, PHCs. The aim is again to provide quality care to mother and baby. And what is quality? If you satisfy your clients, give better services, better results, then it is quality. So Komal, your effort, Q word is very important, and all the best for this CME. And I hope all will be very, very beneficial for us. So thank you. All the best for your this series.
Thank you. Thank you so much, dear madam, for your lovely words. I thank our chief guest, Dr. Madhuri Patel, Dr. Anita Singh, Dr. Manju Shukla, for gracing the occasion. And now, with all the blessings from all our esteemed dignitaries, we begin with the scientific program. And I hand over to Dr. Dinesh.
Yeah, thank you, ma'am. I'm so overwhelmed to hear from Madhuri ma'am, Manju ma'am, Anita ma'am. And I must say that why I used to think that why my sir and ma'am is so excellent, because they've been trained and they've been guided by such an excellent personality. I must say that you all three ladies are the wonderful example of knowledge, beauty, and courage. Now, I know that we all are waiting for a dynamic talk by Ameya sir. So let me introduce with our chairperson for the first session. So we have a first chairperson, Dr. Mala Shrivastava ma'am. She is the head of Gynae Oncology Unit, senior consultant and professor at Gangaram Institute of Hospital, vice president-elect for ISOPOP 2023, past president of AOGD 2021 to 2021. She has been awarded with APJ Abdul Kalam Excellence Award, Subhash Mukhopadhyay Women's Health Icon Award 2021, awardee of the Women Medical and Professional Award by Ayushman Bharat, and also the Hall of Fame recognizing the Stalwart Circle of Excellence awardee by ISOPOP 2021. And also she is a zonal chairperson of ISOPOP. So I welcome you, ma'am, for the session. Let me introduce with our second chairperson, Dr. Vaidehi Marathe, ma'am. She's a
Dinesh, we can skip the intro.
Okay, ma'am. Just in short, she's the director of Mahir Maternity and Nursing Home and in the Nagpur and practices since last 27 years. And she's a winner of MS Signature International Awards 2020, 2021, and excellence has been continued. She's a president of Nagpur OBGY Society. So I welcome you, ma'am. And we have Dr. Samita Bhardwaj, ma'am. She's a consultant gynecologist and established public health professional with over 15 years of experience in the field of sexual and reproductive health. She has also national program manager for the quality improvement in maternity service in private sector too. So I welcome you, ma'am, and I would like to ask our chairperson to introduce our dynamic personality, Dr. Ameya sir.
Yeah, thank you so much, Dr. Dinesh. Ladies and gentlemen, it's my great honor and privilege to introduce our distinguished speaker today, Dr. Ameya Purandare. A brilliant mind, a true gem in the field of gynecology, Dr. Ameya has not only inherited a rich legacy from his father, but also has carved out his own path of excellence. With a combination of exceptional intelligence, unparalleled knowledge, and a captivating oratory skills, he has become a beacon of inspiration for all the aspiring gynecologists. Another aspect, a very important one of his CV, is that he's a very good friend of mine. As you can see from his CV. Hello. Yeah, can everyone please mute themselves? Thank you so much. So he's a consultant gynecologist at Purandare Hospital and Sir H.N. Reliance Hospital. He has held various important positions and currently is the vice president of AMOX 20 to 24, and he's been the joint secretary of Foxy 2019. He has also been awarded with so many prestigious academic awards, which just goes to prove what I just said in his introduction. So ladies and gentlemen, be prepared to be captivated by his insights and enlightened by his wisdom as he shares his experience with us on a very sensitive and a very important topic today. Dr. Ameya, the floor is all yours.
Thank you, Vaidehi. I hope I am audible.
Yes, you are.
Yeah. So, first of all, thank you so much, Dr. Komal and Dr. Niranjan, for insisting that I speak in this very important topic, which is passion for me, because I am a very integral part of the Manyata program. The success of the Manyata program is all because of the support of the Foxy leadership. I think they are the ones who motivate us, who inspire us, who ensure that we keep this flame of quality care in maternal child birth very, very strongly on, and ensure that it spreads across the country, and making sure that maternal outcomes and neonatal outcomes are at all times improving day by day. Special mention here of Dr. Rishikesh Pai, Chief Administrator of the Manyata Initiative, Dr. Hema Divakar, the National Convener, and Dr. Madhuri Patel, the Honorary Secretary General of Foxy. All these three ensure that we at Manyata are always on our toes and ensure that the greater good of the women's health in India is moving to already in the bright future, but even more brighter future. Komal, thank you for asking me to speak on respectful maternal care. And Vaidehi, thank you for introducing me with those warm words. I think the biggest part or the most important part of the CV was that you consider me as one of your close friends. Singh Madam and Manju Shukla Madam, thank you so much for joining us this afternoon and encouraging us as I speak on respectful maternal care. Can I share my screen, please? Thank you.
Yes, sir.
Yeah. Sorry, there's some technical glitch. I'll just restart it. Now, hope you can see my slides.
Yes, sir.
Yeah, thank you. So respectful maternal care is every woman's birthing right. Like Professor Mahmood Fatala, the FIGO president from 1994 to 1997, who's often called as FIGO's philosopher, said women have a human right to go safely through the risky journey of pregnancy and childbirth, a right that should be respected, protected, and implemented. I think this is the entire crux of what respectful maternal care is in the present time and also in the future. So what exactly is respectful maternal care? It's an approach that focuses on interpersonal aspect of maternity care. It emphasizes the fundamental rights of the mother, the newborn, the families, including, most importantly, protection of the mother-baby pair. We called it the Janani Suraksha Yojana. Suraksha is an important part of respectful maternal care. Last but not the least, it recognizes the important fact that all childbearing women need and deserve respectful care and protection, and it's of the woman's right to choice and preferences. Now, humanization of childbirth has occurred over the last 30 years, and most importantly, WHO, through the White Ribbon Alliance, has developed the concept of respectful maternal care in 2011. It has been further included into the WHO Charter, and I'll talk about it a little later. But what is disrespect and abuse? It could be in the form of physical abuse, non-consented care, non-confidential care, non-dignified care, discrimination, abandonment of care, and detention in facilities. This is what we need to avoid because we are infringing upon the basic human right of every mother in labor. From physical abuse, we want to ensure that she has freedom from harm and ill treatment. From non-consented care, we have to ensure she has the right to information and informed consent. From non-confidential care, she has the right to privacy. From dignified, non-dignified care, including verbal abuse, she has the right to respect. From discrimination based on specific attributes, she has the right to equality. And abandonment or denial of care, she has the right to timely health care and the highest level of health care. And detention in facilities, she has the right to liberty, autonomy, self-determination, and freedom from coercion. So keeping this entire philosophy in mind, WHO has come up with what is called as the universal rights of childbearing women. This is the charter that I was talking about. And as you can see, it involves important human virtues such as freedom, such as respect, such as privacy, dignity, equality, liberty, etc. And all these are essential components or virtues of universal health, more important, maternal and childbearing women's health. We've also translated it now in Hindi as a part of the White Ribbon Alliance. Maybe you should download it and keep it in your clinics and labor wards so that the women know that you are genuinely respecting them and caring for them. What do women really want? Do they want respectful maternal care? Let me tell you 3 stories from India. Jyoti from Jahanabad laid emphasis on the pressing need of the presence of family member in labor. Pramila Devi, Ranju Devi, Radhika Devi, Chandravati Devi, etc. are asking for a clean labor room at the government hospital. And Geeta Devi also asked for privacy. These are actual real life scenarios. We have encountered them in our journey of Manyata. What do we need to avoid? We need to avoid being impersonal. We need to be avoid centered on professional and not on the woman and her family. Disempowerment of the woman and the family unit being separated from her during childbirth and labor. So what does respectful maternal care promote? It promotes respect for beliefs, traditional and culture. We don't want to go away from our culture. We want to empower the woman and her family to be actively participating in the healthcare process. We want to continuously support her during labor, motivate her and bring in a lot of positivity. We don't want to leave her alone. We want to give her the choice of companionship during labor and birthing, the right to information and privacy, and the freedom of movement during labor. Also, this involves choice of position during childbirth, good communication between the client and the provider, support of the mother-baby pair, improvement of working conditions, collaborative relationships between all the team members, and prevention of abuse and institutional violence against women. All this is respect, but can this really be extrapolated beyond respect? What is the benefits that it can? Friends, it can be life-saving. And why do I say that? Because in 2008, an important concept came. Women may refuse to seek care from a provider who abuses them, who does not treat them well, even if the provider is skilled in preventing and managing complications. A woman may choose to stay at home without care or treatment rather than subject themselves to abuse and disrespect. What will happen? It will be a non-institutional delivery, a home delivery with all its complications. A life is jeopardized, and that's why RMC can be life-saving. Give her the confidence, give her the respect, give her the compassion, give her the care, and you will save a life definitely. Now, women's rights and preferences should be respected, and therefore you require not a single person. We have a team at Manyata, we have a team at Foxy, and there should be a network of multiple stakeholders. It should be healthcare providers, it should be a community, it should be national leaders like Dr. Hema Divakar, Dr. Rishikesh Pai, and Dr. Madhuri Patel leading these maternal health programs to ensure that it spreads through the length and breadth of the country. It involves an important key stakeholder. Obviously, the pregnant woman and her family is the key or the core, but it involves the healthcare providers, training institutions like we have at Manyata, which are called as CSC, policymakers, donors, human rights activists, and women's advocates. All of them give us important contributions, right? They tell us that we are legally correct, our health policy is strong, our governance is good, the leadership is respectful, the delivery of service meets the standards, quality is not compromised, and it ensures that we don't have any prejudice. If we have this, then the problems of financial access, abuse, geographic access, cultural problems will be reduced. And what we will be able to do is meet the SDG goals 5, that is ensure a skill birth attendant in all deliveries across the world. This was what was proposed as the Hill and Stanton model about the use of skill care utilization and reduce the risk of abuse in childbirth. How can we do this? We can do this with strong policy, legal action, education, service delivery, advocacy, research, and social activism. Friends, FOXY is not just about academics and conferences. FOXY is a social activist organization. We care for the women. We want the women to be healthy because that will ensure that they are happy and ensure that the community is also healthy. There is a wellness in the community which will translate into the growth and development of our country. Let's move on to understand what happened in Tanzania in about 3,000 women who participated in a discrete choice experiment. And we looked at the greatest predictor of health facility preference was kind treatment by the doctor. The attributes and the levels for discrete choice experiment were multiple: medical equipment, doctor's medical knowledge, doctor's attitude, facilities cleanliness, privacy, and cost. They didn't put cost at priority. What they put at priority was the attitude of the doctor, the kind treatment by the doctor. It's not just treatment, the doctor treats me kindly was the most important variable. There has been a medicalization of maternal and newborn care, how much ever we try to deny it. But what is the actual truth? There is a hype about this, but let us see what is the truth about it. What is medicalization of healthcare? The routine use of practices during labor and childbirth that are not evidence-based, that are unnecessary, that do not improve the health outcomes for the mother or baby and may in fact do harm, shift power from woman to provider, and encourage technology or interventions without proven benefit. What are the symbols of this? You treated the body as a machine, you therefore separate the body and the mind, and pregnancy is a medical condition, a pathology, a disease that needs to be controlled. I think this is absolute rubbish. It should never come into a woman's healthcare provider's mind, especially one who is associated with childbirth, because you know that positivity is a key to success in childbirth, successful childbirth or satisfying child. So if it is centered on the professional and there is disempowerment of the woman, that also are symbols of medicalized maternal and newborn care. Friends, let us look into ourselves. Let us take a few minutes to think about the following questions. What drives medicalized maternal and newborn care in your practice or place of work? Consider the origins of the practice. Do you really know whether it is evidence-based? Well, what drives it? Maybe medico-legal pressures, profit, non-evidence beliefs within the community, convenience, perception and illusion of safety, fear, the desire to control birth and reduce risk, and the desire to use technology. Does it really matter? Why does it matter? It matters because costs can be higher, can reduce the access to interventions for those who really need them, can lead to poorer health outcome, does not involve the woman fully in decision making. And this results in her discomfort, more importantly, disempowerment, which leads to disrespectful care. And last but not the least, like the BMG has said, evidence suggests that higher rates of normal births are linked to provider beliefs about birth, implementation of evidence-based practice, and teamwork. I think all of us have realized this in our practice. These three principles are most important. This is a woman who is all alone without a companion in labor. She is a symbol of medicalized model. This is a woman where the family is separated during childbirth and delivery. And this is the companion waiting outside the hospital and not where he needs to be with his wife or his partner when she is going through the process, the risky process of labor, where all he needs to do is be there with her, support her, and ensure that they are in it together. What are the practices that may, in fact, be life-saving? You know that induction and augmentation, cesarean section, episiotomy, restricting food, and electronic fetal monitoring, and routine nasal suctioning. Friends, are these safer or they are life-saving or harmful? Let me present the evidence. Some of the medicalized practices that are actually harmful are restricting ambulation and different positions during labor and the choice of birth position, lack of companion, overuse of anesthesia and analgesia, administration of oxytocin at any time before delivery in such a way that it cannot be controlled, restricting food and fluids, separation of the mother and baby, early cord clamping, and routine episiotomy. Let me give you evidence about each of them. Labor induction has been associated with more maternal interventions, increased PPH, longer length of stay, and high rates of fetal distress on tracing and the need for neonatal resuscitation. Therefore, every labor induction has to be justified. The risk and benefits should be thought of to ensure that labor induction is usually successful and is safe for the patient. There is a big debate about unnecessary cesarean section. The WHO puts its standard at about 10 to 15%, and the standards vary from country to country, from resource to resource. Why is it so? Because the indications are maybe subjective and non-clinical, but they have been found out that the rate of cesarean delivery was positively associated with postpartum antibiotic treatment, severe maternal morbidity and mortality, increase in fetal mortality rate, increase in babies into NICU, and preterm delivery also, and neonatal mortality both rose at rates of cesarean between 10 to 25%. So therefore, are there strategies to reduce unnecessary cesarean? It's simple. Every cesarean that we ensure, and Foxy is doing a lot for this, is indicated, classified as per the Robson's criteria, and audited from time to time. Episiotomy. Friends, we are moving on from the practice of routine episiotomy to restrictive episiotomy. Restrictive episiotomy, as per this study and the summary from Cochrane, showed that women experience less trauma on the perineum, less posterior perineal trauma, less suturing, less healing complications, no difference in the long-term problems of dyspareunia, urinary incontinence, and overall, the women experience more anterior perineal damage with restrictive episiotomy than posterior damage. Hence, episiotomies can reduce maternal and neonatal morbidity if they are restricted to evidence-based indications. An important statement from WHO way back in 2006. Associated morbidity is including perineal tears, pain, and dyspareunia. Restricting food and fluids in labor. Do we really look at it? We need to look at it. There is an unproven fear of aspiration if oral intake is allowed. Allowing self-regulated intake of oral hydration and nutrition has been associated to help prevent ketosis, and the Cochrane review has found no justification in restricting oral fluid or food during labor. Let her eat and drink well, she will be as normal as possible. The choice of birthing position. Gravity is our greatest aid as an obstetrician while giving uh, uh, during the process of childbirth. But we make women lie down on their backs, and therefore the choice of position and labor encourages a woman's sense of control and reduces her need for analgesia. Women who had squatting positions are assumed to have fewer injuries, less vulval edema, less blood loss, while women with non-supine positions at shorter second stage required less pain and had fewer abnormal fetal heart rate patterns. Unnecessary electronic fetal monitoring is something controversial. With technology comes maintenance and cost. More importantly, comes training and interpretation. And the ACOG first noted it with a high variability between observers. There is lack of proven benefit with continuous, and therefore intermittent may be the gold standard, especially in our resources and definitely in low risk pregnancy. Because if the woman is continuously being on an EFM, she has restricted ambulation and positions are also restricted. But let's look at this. Is it really unnecessary? When they compared it directly, they found that continuous versus intermittent auscultation is associated with increased rates of operative deliveries, reduction in neonatal seizures, and no reduction in neonatal death. Analgesia should also be appropriately used because excessive analgesia can lead to longer first stage, longer second stage, and also a greater need for vaginal delivery and surprisingly even fetal distress. Well, the state of mother's report said that the day of birth is the most dangerous day for the mother and baby. And they said this because they said if the mother and baby are kept away, we lead to a dissociation at the very time of birth. We don't ensure this, we don't endorse this, and we don't allow this because we want to promote warming, the skin to skin care, the kangaroo concept, so that even breastfeeding is as early and as exclusive, and the mother has to be counseled about it. Nasal suctioning, 41 articles have shows no benefit. In fact, it's associated with apnea, abnormalities in heart rate, and abnormalities in saturation. Don't do it routinely because it can cause more harm than good. Delayed cord clamping should be done. Think about these three things: say, God, thank you, and then wait for those 1 to 3 minutes, and then you clamp the cord, because late cord clamping has more benefits for the baby: less anemia, less IVH, less enterocolitis, less sepsis, less blood transfusions needed. Especially in premature infants, it is associated with less transfusions and less complications, also with respect to jaundice. Can we reverse the trend? What we need to ensure is that we have an excellent partnership in care. It should be women-centric, empowering, and supportive. Don't compromise on evidence. Don't compromise on quality. Ensure that every woman is treated equally and equitably. For example, ensure that you give kindness in your behavior, make the drugs available, make the place of birth clean and culturally appropriate. Ensure that there is companion support. What about the midwives? In these outcomes that were shown, if it was a midwife-led continuity, it is shown to experience less problems in the group, and they are more likely to experience more problems if they don't have midwives. So we must work with midwives, not separately, but jointly. What should be the tips and for the providers? Wait and see, get her off the bed, justify your intervention, listen to her, be a role model, be positive, and promote skin to skin contact. The birth companion is absolutely essential. He improves birth outcomes and the overall birthing experience. Continuous empathetic and physical support is associated with shorter labor, less medication, and fewer operative problems. But as a doctor, we have certain important roles. Take the responsibility for your own decision. provide care that is evidence-based and shown to be beneficial, first do no harm, record and report, communicate, be the woman's advocate, and explore opportunities for collaborative working and team building. That's what Manyata is all about, to improve respectful maternal care. Absence of disrespect and abuse is not equal to respectful maternal care. This is the quality of care model that is there. There should be provision of care, experience of care, and all this. So competence and quality is equal to respectful maternal care. This is WHO's vision. The most important standards that WHO mentioned in 2016 are communication, respect, support, and competency. These are the 4 important things. We are using them in Manyata as essential clinical standards or essential policy for facility providers. Manyata was started. I'm proud to be a part of this, and it is the Quality Assurance and Quality Improvement Program. It's FOXI's flagship program, and we are ensuring that we are spreading from Uttar Pradesh, Jharkhand, and Maharashtra, where we began in 2018, to much higher, much larger geographies. And I'm sure the day is not far. It is not a dream. It will soon be realized that the whole India, from north to south, east to west, will all be a part of the Manyata journey. It's a quality stamp. We began with Uttar Pradesh, Jharkhand, and Maharashtra. We have a lot of partners like MSD, Japaico. Initially, we had MacArthur also, but it's FOXI which is driving it. It's FOXI which is training everybody, which is setting the scene. And then we have an effective certification mechanism. We now have even very effective virtual certification. So that's the coverage. These are the 16 standards. They range from antenatal, intranatal, beyond delivery, postnatal, and even the Caesarean standard. This is the certification that we offer once you complete the Manyata assurance and the quality assurance and the accreditation journey. And this is awarded to every facility. But is it really making a change? So we are looking at the feedback with Quality for Her, and these are the various parameters that we are looking at, and these feedback points are objective, reliable, and actionable. This is the snapshot of how we are looking at the feedback program, how it is making a difference in maternal and neonatal outcomes. This is how we assess. Some of the common things are skin to skin, breastfeeding, and family planning. And this is the test before Manyata was there. And the second group is when after Manyata was launched, post-registration, and you will see that there is a marked improvement. The Government of India 2017 has launched the Lakshya program. In Maharashtra, Lakshya and Manyata is a joint collaboration, and therefore we are hand in hand with the government. The government has realized the strength of FOXI and Manyata, and we are very effectively carrying it out in the state of Maharashtra. And I'm sure that all the other states will soon follow us in this entire Lakshya Manyata National Label Route Quality Improvement Initiative. So friends, the key messages are: we need to include advocacy at all levels, have important networks, involve the community and media. Where data is absent, conduct studies on women's preferences and choices, ensure political commitment at every level, national, district, and local, for helping us to put the policies in place. Professionals and communities should collaborate. Knowledge, skills, and attitudes that support RMC must be required in all education and technique, and mobilize resources to support the implementation of RMC. Friends, I end by simplifying RMC through few pictures. Make childbirth a memorable experience. Make every mother feel valued, respected, and cared. Make her feel special. Empower the woman, inform the woman. Take her permission for conducting medical procedure, because every woman has the right to information, consent, refusal. Respect her choice and preferences during maternal care. During examination, be gentle, comforting, and reassuring. Every woman has the right to be free from harm and ill treatment. Privacy matters to women. give her the right to privacy and confidentiality, provide curtains and screens, and keep her records and details confidential. Allow a companion of choice to every woman through labor and birth, because every woman has the right to companionship during maternal care. Ensure that all women are equal. Give her the respectful care, irrespective of her ethnic background, culture, social standing, educational level, or economic standing. This is the basic right of humanity, that all humans are equal. They are free and they should not be discriminated at all. We for Stree was the campaign that we launched when I was the Joint Secretary of Dr. Nandita, who launched and signed the Lakshya Manyata program. We ensured that through quality care, through respectful care, that every woman in labor is safe, strong, and smart. Friends, I end by this quotation. Respectful maternal care is a human right. Respectful maternity care is a necessity, is necessary. It is achievable, and it is every Foxian's responsibility. Thank you so much.
So I would just like to thank Dr. Ameya Purandare, sir. I think that was an excellent presentation, covered all important aspects of RMC. In fact, I learned quite a few new things today with your presentation. So thanks for that, sir. And also, I think, firstly, what I want to say is that thank you, Dr. Komal, Dr. Chavan, for inviting us and inviting me here, and really thankful Dr. Madhuri Madam, who's always supporting us with this project. But and Dr. Hema Divakar Madam, you joined at the right time. So I'm just going to take just one more minute, saying that it's so heartening to see that Foxy and all so many stakeholders are now equating Manyata with quality of care in maternity sector. And I think that really talks a lot about, all the 6-7 years of work that we put in together. I see so many of Manyata champions in this screen today. So I really thank everybody for really, talking about quality, talking about dignity, and, RMC, etc., and all those important topics. Manyata covers everything. It is based on 16 clinical standards. It is a very, very important program, easy to register, easy to undergo, and certification is the end point. So with that, once again, thank you, Dr. Ameya. Excellent presentation. And thanks, Dr. Komal. Also, Dr. Vaidehi, my co-chairperson. Lovely meeting you. Thanks. Yeah, back to the organizers.
Thank you so much, sir, for such a wonderful and informative session. We are now pleased to announce our second session on the topic of labor room standards to ensure safe delivery.
Before we go to the next session, I would like to thank Dr. Ameya Purandare, who has given good points. He has taken good points on his lecture, and Samita, and of course all the chairpersons who have come. Komal is seeing one patient, so I'm now taking over. And thank you, Hema Madam, to join. And I'm really grateful to all of you for giving your valuable time to come here. Thank you, Madam. Now we move, and I thank Dr. Vaidehi Marathe, and of course Dinesh and other coordinators, Monica and Anita Singh, who have joined earlier, and also Vinita Singh. Welcome, Dr. Manjushree Boob, and I can see Tarini Madam also being there. Dinesh, your introduction was just superb as usual, the way you are. Thank you, Dr. Nalini Sharma and Ragini Singh, Hitendrasingh Rajput. Now, I would like to hand over the mic to the next, the master of ceremony, to take over further.
Yeah. We have our second session on the topic of labor room standards to ensure safe delivery, featuring 3 chairpersons, Dr. Archana Verma Madam, Dr. Nalini Sharma Madam, Dr. Manjushree Boob Madam. Can we have the introductory slides, please?
Yes, sir, it was displayed.
I'm not able to see. Okay. Dr. Archana Verma, madam, she has done her MD, FICOG, and she is also a member of RCOG. She was the vice president of the FOXY in the year of 2021. She was the founder president of West UP ISO PAP chapter and advisor of UPCOG. She was also organizing chairperson of UPCOG in the year of 2020. She was the past president of Ghaziabad Obstetrics and Gynecological Society. She has received award of Dhira Award in 2022 for the Women Health and DC Datta Award for the Best FOXY Focus. President FOXY Best Committee Appreciation Award, and she was a faculty in more than 600 national and international CME. She has also received Wonder Foxian Award for the work in the reproductive health of women, and she has also received Award of Champions FOXY 2019 Award. Next. Dr. Nalini Sharma, madam, she has done her MS, FICOG, FIACOG, FMAS, and FICMCH. She is the associate professor in the Department of Obstetrics and Gynecology. She is the member of IAGE, ISAR, PCOS Society, FOXY, MRC, and SOGS. She has more than 80 publications in indexed international and national journals and multiple extramural projects with ICMR. Next. Dr. Manjushree Boob, madam, she has done her MD, DNB, FICMCH, and FICOG. She is a consultant obstetrician and gynecologist in an infertility and laparoscopic surgeon. She has done her fellowship in laparoscopic surgery from France and fellowship in test tube baby from Germany. She has received award of Wonder Foxy and many more other awards. She has publications written and published a book on adolescent.
So anyway, it's okay. Now I know where you are. Yeah, so that is the reason. So don't worry. So now I'll write down to you these medications.
Okay. Madam has also written published a book on adolescents' health and sex education for blind students in Braille, and organized a state level FEMCON 18 conference on IVF and Amravati, and organized many more infertility and IVF free checkup camps, and worked as president, vice president, secretary, and treasurer for Obstetrics and Gynecological Society in Amravati. Furthermore, we are delighted to have Dr. Hema Divakar, madam, as our speaker for this session. I now hand over the floor to our chairpersons to introduce madam.
Thank you so much. Thank you so much, Dr. Chavan sir and Komal ma'am, for inviting me and giving responsibility as chairing session of my dear friend and a person whom I admire a lot, Dr. Hema Divakar ma'am. Speaking about her, she is a medical director of Divakar Specialty Hospital, senior consultant OBGYN, CEO and chairperson Asia Research and Training Institute of Skill Worker, Dean Karnataka College of OBGYN, and Vice President Karnataka AHPI, Chair of Well Women Healthcare FIGO, President DIPSI, ex-Vice Chair for FIGO PNCD Committee, past President of FOXY 2013, and advocate for delivering quality healthcare convener Manyata. And I know Manyata is synonym to Hema Divakar ma'am, and everyone of India and FOXY will know Manyata and Hema Divakar ma'am together. An opinion leader and influencer for social and legal issues relating for women health, received FIGO Women Achiever Award 2015, received Global Asian of the Year 2018, received CME Excellent Award for Artist, Next Brands Award for Artist for her, received CSR Time Award, CSR Impact Award for Divakar Service Trust. So herewith I present to be very smiling, ever helping international figure from our India, and who is a faculty and who is a phenomenal work in the field of not only OBGYN, but also in her social fields also. So ma'am, floor is yours, and we all are waiting to hear you, ma'am.
Namaskar.
Welcome,
Thank you
dear
very
ma'am.
much. Manjuri, you've been really very, very kind. And I was like not knowing where to look when you were saying so many good things about
No,
me.
ma'am.
So thank you so much for your
We
love.
adore
I can
you.
see.
We adore you, seriously.
Nalini, Tarini, Vinita,
Good
Ragini,
evening,
and all my very, very dear friends and champions who are here on the screen. My humble regards and salute to all of them, because whatever we do, it's really, really the trust that all of you people have had in the leadership, and we've pushed our agenda ahead. So thank you ever so much. And just now you had the insight into the Manyata initiative. And the topic that I was discussing with Komal, who has so kindly invited me for this session, is called Readiness is the Key. Believe me, everybody knows potentially that any low-risk pregnancy also can suddenly turn into a disaster during labor. They know also that there are so many things that we have to be alert on, and we have to be ready and keep this, that, and the other. But still, when the calamity happens, we should have done this. We should have done this long ago. Why didn't we do this? Retrospectively, anybody can look and blame anyone. So that is the usual story which goes on. And if we need to save lives, just let me give you one example of the preparedness for PPH. Because readiness for PPH, especially in our country, it's a given. Means we have to absolutely be ready for a variety of reasons, including the basic status of anemia of our women. India is perhaps the only country where 20% of the maternal deaths are directly related to her being anemic before embarking into her delivery room. So that is what it is. Can you see my slide, Manju? Can you just confirm that you're seeing my slides, okay?
Yeah, ma'am.
Okay, great. Thanks, Nalini. So when we say be prepared, okay, this is a story of a fairly young primate. What went wrong during her checkup? One antenatal visit. Now we are having some incentives, more and more bookings, but we have to strive to motivate our women to find a value in her checkups. We say 4 antenatal checkups. Why are people coming only in the 6th one? Because they think, okay, at least one injection is given, when a dabba of tablets are given. So there is something that she will get out of that visit. Early antenatal visit, we say first trimester. First trimester, she comes, there's nobody even talking to her, and she just pushed from one corner to another corner. Abhi kya, some folic acid tablets, maybe, may not be. So she doesn't want to miss her daily wages, come to the clinic, especially a public health center, stand in long queues, still get nothing out of it. And so her visit should be with value add. There are a number of times hemoglobin is checked, but is it corrected? Is it not tested at all? Or it's tested, but nobody is paying any attention to it. It is tested as a routine protocol. Sugars, again, there is a huge gap. Now, the Manyata program, which Ameya was talking about, we thought in the private sector, 2014, we got the recommendations from the government that universal testing, guys, every pregnant woman need to be tested with the sugar, do the 75 gram, do not. We are telling on many forums for how many? Last 10 years. And still the coverage is only 28 to 30%. And believe me, every private segment which we take for the Manyata training, the very first session, almost 90% of the private practitioners, if we ask the staff, they come out with all kinds of miscellaneous answers. We do random sugar, we do fasting, we do 100 grams. But it is such an easy thing to teach and make them adhere to the protocol. That is the readiness. The staff should sing the same song as how the boss is singing. The boss may not have the time, but the entire team should live up to it like an orchestra. Once, one lesson, 10 minutes, and by the next week when they appear, they would have sent us at least 50 records of the single step test that they have done. What was the change? This was readiness and the mindset and the attitude to do what needs to be done. This patient had polyamnios. The staff was unaware of active management of third stage of labor. Within 1 minute, they had to give something. They didn't. So who needs to be ready? It's the women and her families. It's the infrastructure, which is rather easy to gather, but frontline healthcare providers. You see this whole team of people where they are paying attention after the training to be ready to correct anemia even before the pregnancy or fairly early in the first half of the pregnancy, to make sure that every patient that steps into their setup is anemia free. She has a better chance or a good chance of surviving through the labor, even if she has the PPH. And like how I said, 90% were not doing the single step test. The same way in the very first session, Manyata standard number 2, we say readiness is the key. So please keep the readiness for normal delivery, the baby tray, the PPH tray, the eclampsia tray, etc. Believe me, 80% of the setups have to then buy the plastic dabba, and they have to place all the things which we have given in the list there. And then we say, whenever a case of PPH happens, early identification, call for help. Your colleague staff nurse comes to you with the box which is labeled as PPH kit. And once you open that, then it's like a flashback. Everything that is put in the box is needed for you to take care of the patient. That is readiness to our mind. So preparing the women, pre-pregnancy anemia. You could have always checked for the risk factor. Did she have a previous PPH? Is she a case of previous section? Does she have any other unusual things like hereditary coagulopathies? Obesity itself is one of the risk factors. So pre-pregnancy, do you have a chance to get her into optimal weight, be ready, and then embark into the pregnancy? Well, early and mid-pregnancy, the scans paying particular attention to placenta previa, accreta, increta, percreta, and the other comorbid condition inclusive of PIH, HELLP syndrome, etc., which can really make the situation complex. Then closer to term, again, whether it's a multiple gestation, more prone to overdistension, or it's GDM with a large baby with polyhydramnios, or the placental position is such that you're anticipating problem, you are paying attention at every stage. You're preparing your mind about what to be ready with, how to alert the women and her family, and at delivery, the blood products to be ready, and patients and the relatives made aware, decide the place of delivery, counsel the family, etc., etc. So indeed, again, I emphasize, there is an opportunity for us to be ready, and readiness is indeed the key. So what did our organization want to do by establishing a skill health academy? They all know, but they don't do. The gap between knowing and doing is the problem. Why they don't do what they know? That's because small gaps in their understanding. Little bit capacity and confidence has to be built. And the boss also has to trust them, give them enough practices with the skill drills, and each time make them speak, make them do, make them speak, and make them do again and again and again. The gap between ideas and just the jotting down in the classroom should go, and the actual on-job skill, job ready and skill is what we want to create. So the vision is to skill India, and especially in the maternal and child health care. We say very proudly we have 40,000 gynecologists. Fine, then we say we have 30 million deliveries in our country in 1 year. 40,000 gynecologists looks like a large number, but not enough to take care of 30 million deliveries happening in our country. So what we need, at least 1 million skilled healthcare providers who are ready to give care in the antenatal, interpartum, and postpartum care, as Ameya just mentioned. So the FIGO's masterclass, understanding the less understood, was and really in the low middle income countries, we have less understood the potential for us to be ready, train our staff, and train all the team members to seamlessly deliver the care, standardized care, adhering to the protocols. And how can we reach the nooks and corners? You'll see that from the physical on-site skill training, this entire thing is transferred on the digital platform, any nook and corner. The only difficulty we are finding is in the language. So we have master trainers in various languages. There's a Kannada batch, a Tamil batch, a Odia batch, as we just started yesterday. The Assamese, the Hindi, Marathi, and Tamil are, of course, there. So the staff needs to be addressed in their own language, and we have to collaborate to build the capacity for making childbirth safer. We're today working in many states, pan-India, and Foxy has been of a tremendous support. At the same breath, I must say, all our champions within Foxy have stood in the front line to train the frontline providers. So this is an old slide, 4 lakh, 14 lakhs, 40 lakh women have been reached. And again, practice, and practice. Readiness, recognition, response, and reporting. when we saw less than 50% of the hospitals had massive hemorrhage protocols, they were not performing the risk assessment and the drills, they were not used to measuring the blood loss, even these basic presumptions that they may be doing this, even big institutes, it's really, really a gap. And once we train them, you would see the percentage of adherence anywhere from 99 to 100, because it is simple to do. They may be having one or two gaps in their understanding, plug that gap, and you will see that it's a low-hanging fruit. Everybody can learn because that's what they have been trained to do, but they're not doing it. So that was the kind of gap that we are very seriously and sincerely trying to build. So the feedback that we got, Ameya spoke about feedback from the patients, but we are speaking about the feedback from the heads of the institute and the staff nurses themselves. The level of confidence, the in-depth knowledge, the resuscitation, they all uniformly said, no, we will wait for the pediatrician to come. But when we told them, you are the key person because it's the one golden minute, and the pediatrician cannot reach there in that one golden minute. So you have to do the best that you have to do. And now everybody, all the bosses are surprised that the initial action is rapidly the PSSR, positioning, stimulation, suction, and repositioning is done by all the staff nurses. So enthusiastic, so engaged, and so proud of themselves that they have built the capacity and the certification given. To assess and do an audit what impact it has had. So we just recently as January 2023, in the Clinical Case Report International Journal from our organization, wrote out a paper strengthening the quality of care for safe delivery through capacity building of frontline healthcare providers. The three main things that we assessed was the single-step testing, anemia check, and respectful care during the antenatal, the PPH management and active management of third stage, the pre-eclampsia, eclampsia knowledge, and institution of the magnesium sulfate dosage. I can vouch for the fact that all our Manyata trained staff nurses, in their dream also, they will tell you the exact dose of magnesium sulfate loading and maintenance which needs to be given. And partogram, which was a big gap, they have now recognized that the progress can be monitored and they can inform their bosses, no, this patient is likely to deliver very quickly, or no, this patient is really badly stuck. So all of these changes. So the pre and post testing, when we ask them glucose test, should we have to do for all women? And can we do it non-fasting? Should we do active management for all cases? Is diazepam the choice for eclampsia management? Plotting of the partogram, should it be started at 4 centimeter or before, or what? So when we just took this sample of the pre-testing, we recognized the gaps which were there. We wanted to keep them ready, and we did train them through the digital platform, very, very simple manner. And Bihar, Tamil Nadu, Punjab, Maharashtra, the statistics are here. The change in performing the single step test rose from 16% to 89.4%. And in the state of Maharashtra, with all the 4 states we've analyzed similarly, the understanding that use of diazepam was not the first choice for eclampsia treatment was only 37%, but it rose to 88.5% after the training. So magnesium sulfate underutilized, not widely adopted. They want to just pack the patient and send them to the next institute. Instead of that, now, even though they cannot handle there, now most of the cases are handled in their own setup. Even though they cannot handle, they will give the magnesium sulfate dose and then send them further. Performance of active management of third stage. It really doubled in all the 4 states. This is such a simple thing to do. Just give me a moment. Yeah. So it doubled in the 4 states because this is such a crucial step, which is a life-saving step. So readiness with the oxytocin bought from the refrigerator and kept in the labor on the labor table just at the time of full dilatation. And the boss is saying, oh, this one was working with me last 15 years and she's never done it before. And it's just a question of a small tweaking of her understanding that this needs to be given within 1 minute after the anterior shoulder or the childbirth made a sea of difference. Partogram plotting, it's 100% in Tamil Nadu, but everywhere else you will see it escalating more than threefold of what they were doing before. So upskilling of the healthcare staff definitely brings about the improved maternal outcome, and all the 4 standards on an average, whether it was in Bihar or Punjab or Tamil Nadu or Maharashtra, you see it scaling up into much higher level, and it really has become a game changer. Then we said that individual nurses, this is a group, and many times when we take the test, first 2-3 people who are very bold, very courageous, want to open their mouth all the time, don't even give a chance to the others to speak anything. So how can we be sure that everybody in the team has learned well? That was one concern. The second one was that when these individual nurses leave the setup and go elsewhere, what is it that they have in their hand? Because the hospital gets the certificate like a Manyata certified center, but the individual nurses, now we have tied up with the Health Sector Skill Council, and they have to appear for an online theory exam. 70 out of 100 should be the marks that they would score. And each one of them individual assessment of 10 skill sets. With that, you will see that 100% of our nurses have passed. And just look at the scores here. This is a Tamil Nadu data. 100 on 100, 90 on 100, 100, 100, 100, 71. It's 80, 94. That means it's not, they know half and half. First of all, the pass is 70 on 100 is the minimum they must score. But all of them have reached such a level of excellence. We are really proud of them. And they get their individual certification, which gives them extra incentives when they go anywhere else, to any other setup, any geography, any corporate hospital. They know that if she is a Manyata trained nurse with this certificate, she will know basic these 16 standards to do it well. And the e-health programs have really escalated enormously to help us reach the last mile. Readiness to tackle the patient in her own home. Now, many of these devices, frontline healthcare workers, the community volunteers called Swasthya Sakhis in our villages, the ASHA workers, we just put all these gadgets in their bag, and home to home when they are going also, they can do the NST, they can do the digital blood pressure, they can do the glucometer test, they can advise them a thing or two and alert them when to visit the hospital. This is a new device called the Baby Beat, which we give even your receptionist can just put it on the patient's tummy, and then she can send you the graph by WhatsApp, and sitting at your own home, you can say, okay, this patient is GDM, she's come with less movements, but this graph is excellent, she's doing well, you can send her home. Same with PIH and anxious IVF patients. No longer we need the heavy missions and the belts, etc. So these are made in India products, and the future is very much here. So this is a paper we produced about overcoming challenges of traditional in-person prenatal care. We did a pilot study on the usability and acceptability of a remote monitoring device for pregnant women in India. Nook and corner in the villages also where they don't have access to NST machine, etc., but it needs to be done for the fetal surveillance. These kind of devices can easily be utilized by the semi-skilled person. They're always ready, and readiness is the key. Just look at the scenario: access, affordability, quality of care. All of these we can do. And the millions of smartphones which our women are using, 1,130 million subscribers in our own country. We have problems in our country, but let's talk solutions. Cost-effective solutions of skill transfer through digitization, technology. Yes, we agree that touch and face-to-face is important, but reaching the unreached when they cannot do any better, at least this much and much more. These are the individual skill tests being taken by the staff who have to actually demonstrate each and every skill. inclusive of hand washing, blood pressure measurement, partogram plotting, gloving, degloving, the demo of active management and control contraction, and the breastfeeding methodologies, neonatal resuscitation, etc. So all those standards which Samita and Ameya brought forth to you, this qualifies them individually to get a certificate called Assistant to Maternal and Newborn Care. The eligibility for this is even 10th standard, 12th standard pass, because we skill them. They have to do a 3-month apprenticeship in any of the maternity homes, and they know most of the things because they're just keeping things ready for you. Readiness is the key, and you don't have to run helter-skelter and waste the precious minutes, and they're all there. Here again, you will see a brilliant score by the skill sets that have been developed with ANM, GNM, very, very basic qualification, and they get a sense of self-worth because till now they were working with their 2 hands and 2 legs moving around in the setup, but now they have appeared actually for an exam. They proudly hold a certificate in hand, and they really feel they're an important part of the issue. So here you will see the CEO of NABH, the state leaders of the Association of Healthcare Providers of India, and the CEO of Healthcare Skill Sector Council from the ministry, who have co-created this course with us for individual nurses from all over in the pilot project in Karnataka. You can see them beaming and proud of the accomplishments that they have done. We have also invaded the ASHA workers. We are doing short courses like Anemia Mukta Bharat, Poshan Yukta Bharat, and all of these, and they love it because their understanding has really scaled up 100%. And all of these team of community volunteers, paramedicals, and the young healthcare ambassadors and assistants loudly and clearly say, yes, we will pay attention to details. Yes, we will do more than what we were doing before. We are proud of our certification and we are ready because, ladies and gentlemen, readiness is indeed the key to be prepared and to save lives. So with that, I once again thank Komal and team and all the beloved chairpersons and champions on the screen. A heartfelt thank you for making me a part of this fine evening. Namaste.
Thank you, ma'am, for this elaborative, excellent and nice, wonderful presentation. And it's a great privilege to share this platform with you with such a international figure.
Thank you, dear. And we are making our voice heard loud and clear on the global level, because now many are saying, low middle income countries, how could India have done this? Okay, and if India has done this, then anybody should be able to do it in the whole of South Asia and Africa, etc. So we always wanted to be proud to role model and showcase that despite all the challenges, yes, we can do. And for that, my trusted champions, I must really once again very humbly thank all of you to have made this happen. Thank you.
So you always mesmerize us, Dr. Hema Divakar, ma'am. So always I love to hear you.
Thank you. Thanks, Vinita.
Thank you so much, ma'am.
Now
we
Dr.
hand over
Hema
the
really
mic
loved
to-
your talk. Dr. Hema really loved your talk. Really happy
Thank
to
you,
be here.
Tarini.
Yeah.
Komal, thank
You're
you for
always
inviting
been-
all my beloved friends whom I wanted to meet for a long time.
Really
Tarini,
good inspiration.
Manju,
Good
Vinita,
inspiration
Dinesh.
for us. For spirit for
Thank you,
rejuvenation,
madam.
rather to say.
Thank you,
Niranjan.
madam.
Thank you, madam.
For joining. Yes.
Hi,
It
Niranjan.
was a wonderful talk.
Madam,
covering-
all the best. Madam, all the best for your ego venture, and let Almighty be with you.
Thank you.
Madam is a true leader, and the amount of the effort, it is like a humongous effort which you have done. So much work has been done to uplift the maternal health, and all credit goes to you, madams. Really lovely. Honored
Thank you,
with
Komal, and all the very best.
Yes. Thank you, madam. Thank
We
you
will
so
be
much.
together in our endeavors and fight ahead.
Yes, thank you, madam. Thank you.
Hello, Komal, I joined.
Yes,
They-
thank you, madam.
You know,
Ah.
always this Archana says, there hai, अंधेर नहीं. So देर है लेकिन अर्चना, the shining star has come.
Yes. So she had to be here. We are very happy, and we just finished Madam's talk. It was really an eye opener, and really we have so much to do, and so much has been done. That is very good.
So thank you, chairpersons and the Hema ma'am, and I'm totally, it is a wonderful lecture, and I must say that each word of yours was telling the magnificent experience you are carrying, and your perspective visions will definitely come up with a golden era in the field of obstetrics and gynecology, and definitely we budding obstetricians will gonna have a wonderful time ahead. So I must say that now this modern obstetrics is going towards the civilized and the sophisticated and evidence-based obstetrics. So thank you, ma'am, once again for your wonderful lecture. So again, now we are going ahead with the third session, and we have very renowned speaker of our own, Komal Chavan, ma'am, and it is again one more opportunity being a student of her to attend that lecture. So let me invite our wonderful chairperson for this. So we have Dr. Tarini Taneja, ma'am. She's the chairperson of Delhi ISAR, chairperson of Breast Committee POXI, international member of FIGO Working Group of Breast Disease. She is having the publications in infertility, breast disease, and lactation. She's been awarded with the Bharat Gaurav Golden Icon Award, and also she is the Lifetime Achievement Award by the government of Uttar Pradesh and Family Planning. We are really very honored to have such an enthusiastic personality today with us. Welcome, ma'am.
Thank you, dear. Thank you, Hira. Thank you.
Let me to welcome again Dr. Vinita Singh, ma'am. She is Associate Professor in the Department of Obs and Gynae at Patna. She is a consultant at Care Hospital and IVF Center. She is the President of Obstetrics and Gynae Society and Foxy ICOG Governing Council member. Also, she is the East Zone Coordinator for the MTT Committee for the Foxy, and she participates in FIGO Vancouver 2050. And she's been invited for the many as a faculties for many more national and the local conferences. So we have such a great personality among us. I think this will be one of the memorable evening in my life, I must say. So welcome, Vinita ma'am. And yes, we have...
Thank you very much.
We have very lovely personality with us is Dr. Ragini Singh, ma'am. She is a senior consultant and the past president of Jamshedpur Obstetrics and Gynecology Society, and past president for the Obstetrics and Gynae Society at Bihar and Jharkhand. Manyata champion from the Jharkhand Pillars, and also she has been awarded with a very prestigious award called as BCRI Award. And yes, she has the one who has organized the first All Jharkhand Conference as a president, and she's actively involved in various NGOs, and her philanthropic activity makes her to be a very remarkable personality in the field of obstetrics. So I welcome all this chairperson and formally to introduce our speaker. So handing over to the chairperson now.
Dinesh, welcome. Archana Verma madam also, she is joined now. So you can...
Okay, welcome Archana ma'am. I
would like to thank Dinesh, 1 minute. I would like to thank the organizers for inviting me here. Thank you, Dr. Komal Chavan and Dr. Niranjan Chavan and all the organizers. It is really a nice meeting so many people at one stage. Thank you so much.
So now I would like to introduce our star speaker for today, Dr. Komal Chavan. We all know Komal is so many quality, but she's a passionate to work for the women health. She's already working at the Foxy platform in many capacities. At present, she is the chairperson of the medical disorder of pregnancy. She has worked at the MTP committee of the AMOX, and she has now working as the West Zone coordinator of Foxy. She has been awarded for the Meru and Sotia Award and many more awards. And she is really lovely person.
Thank you.
And
thank
very
you.
good friend to me. And many thanks to Dr. Niranjan, and to you for giving me this opportunity, and also to Dr. Dinesh for coordinating very well. My warm regards to Dr. Hema ma'am, Dr. Madhuri ma'am, and all the guests of honor, and my co-chairperson Ragini Singh, and the other one also. I'm just listing her name.
Vinita,
so thank you.
Vinita
Singh. Oh, Dr. Vinita Singh. So floweringly, you are okay. So now, not to take much time, and Dr. Komal, is a podium to you, and Dr. Ragini, many congratulations for your VCRI award. It's news for me.
Thank you.
Thank you.
So,
Thank you.
very
Thank you.
good evening to all participants. At the very outset, I would like to thank Dr. Komal Chavan and Dr. Niranjan Chavan. And Dr. Komal, you are a lovely friend of mine. Whenever I see you, I hear you, it really mesmerizes me. So it's nice to see you on this platform. And today we all know that cesarean section rate is rising day by day. And for the last 30 years, it has increased by 10 to 15%. It's high. So in some time we have to do cesarean section, but we are more concerned with the cesarean section, which is being done unnecessarily. So we have to think on this point. We all Foxians, government is also taking and talking on this point to reduce cesarean section rate. So let us hear from Dr. Komal Chavan, optimizing cesarean section rate. So the floor is yours, Dr. Komal. Let us hear from you how to optimize the rate. Dr. Komal.
Thank you. Thank you so much, Dr. Tarini, Madam, Vinita Singh, Ragini Singh. I think thank you for your presence here and the kind introduction and the introduction of topic, everything. Thank you, Dinesh, for coordinating. I had two speakers who spoke so well, Dr. Ameya Purandare on respecting maternal care and Dr. Hema Divakar on the quality improvement in labor ward. I think they have actually focused about what we need to do and how the basic things need to be done. But what is now is important is the cesarean section. And that was the idea to put cesarean section in this talk, because cesarean section is one of the most common surgery which is done in gynec and obstetrics. And we need to optimize the rate, and also along with it, we need to give a quality care also. It is not only optimizing the rate, but we need to give it as a quality. While we are optimizing this, we need to see that the cesarean sections are done and a quality care is given to the mother. And I would also like to welcome Dr. Archana Verma, the past Vice President of Foxy. She's also joined in here, and she's also done a lot of work. She is very good in public awareness. And when we talk about Archana Verma, we know that the information, the awareness which she does, the activities which she was done, they were nationwide. It causes a revolution. So I'm very happy that she has joined in for my talk. And now I begin my topic, optimizing cesarean section rates. We know I don't want to call it as reducing or something, but we really need to optimize. We need to introspect, and we need to know if we are doing what we are doing is right or no. So we'll begin with a quote. If you change the way you look at things, the things you look at change. And we really need to see the newer changing trends in cesarean section, the indications, and the new epidemic in India. So coming to the background, we know that it is a massive jump. These are just rough figures and estimates which are coming, but it is increasing day by day. In fact, in private sector, and it is more doubled than the government sectors, but even government sectors, wherein there are tertiary centers, the rates are pretty high because of the transfers and refer. So what is happening? It is just a blame game which is happening. We get directives from the government. They feel that it is an unregulated rate. They feel probably it is because of the financial incentives. There is also some trend in some women who are getting pregnant after an infertility treatment. So they feel that yes, cesarean is a safer way out. So there is also a trend that women opt out for a safer delivery. They don't want any complications. They don't want to undergo the normal pain. So there are so many factors. So all these is what is actually spoken about everything. But why are we worried? Because alarming cesarean section rate are not only in India, but even all over the world. And certain indications are unwarranted. Like sometimes you do a cesarean section and you put an indication, it may not be the absolute indication for cesarean section. And sometimes what we feel, like now this is a high risk patient, or now we feel that this patient cesarean is a safer way out. And so this is an assumption. So counseling of patient also needs a very important, because it's not always that cesarean is a safer way out. Failure to understand the natural progression of labor. Many a times, like if the patient is not gone into labor, coming near term, or patient who is in labor for a very long time, we don't wait till the natural progress starts. There can be an early induction.
And then that patient who is induced early may not progress. And then we think that it is a failure to progress. So understanding of this is also so important. Also, the ignorance about there may be some long-term implications on women's health also, because it is a surgery. You do one cesarean, it leads to a previous cesarean, then previous two cesarean. All that becomes all related and becomes a cycle. Also, we are worried that why are we doing now? Because of the ART conception, which I already spoke, but also the lifestyle changes. There are so many, the Western culture, we are having a lot of pregnancies which are complicated by medical disorders. Pregnancies are becoming higher risk. The maternal age is also rising. So these are the patients who we really, they probably want, they have multiple high risk factors. And all these may be some factor which may be contributing to the increasing rate of cesarean section. So when we analyze, WHO has actually made a statement on the cesarean section that yes, cesarean section is a life-saving thing which saves the maternal as well as infant alive, but to be done only when medically indicated reasons. And at population levels, cesarean section rates higher than 10% may actually not be associated with maternal or newborn mortality rates. It was the balance by a larger studies, they have shown that it is not all that improved. Cesarean sections can cause significant and sometimes even permanent complications, like even complications intra-op or even death are also common after cesarean section, and there are also surgical complications. So we need to make every effort to do cesarean section only in women in need and target to achieve a specific range. And effect of cesarean section on other outcomes such as maternal, perinatal, pediatric, psychological, social well-being are still unclear. And more research needs to be understand the health effect of cesarean section on immediate and future outcome. And this was a WHO position statement around in 2015. And from that, a lot of studies which shows that India actually has improved the maternal mortality rate in at least in the state of few states like Kerala and Maharashtra. We have a good figure. We have reached almost 33. Still in other states of India like Uttar Pradesh and North, we still have to achieve our SDG goals. But some and even the neonatal mortality rate also has significantly lower down in certain states. So it is there that probably the cesarean rate definitely is more, but the outcome, the analysis and more studies needs to get published to show that the rate, even though it is more, these rates have come and they are little better, the mortality rates and the newborn neonatal outcome. So talking about the complications, we know all the intraoperative complications. Like a cesarean section will have a wound, so there would be infection, there can be bleeding, there can be bowel bladder injury, there can be risk of amniotic fluid embolism. Anesthesia, which is given, is also at risk. The baby is said that baby may have an altered immune development, increased chances of developing allergies, asthma, reduced gut microbiome diversity, which is coming up in a bigger way. And this gut microbiome diversity is also linked to a lot of other lifestyle issues, endometriosis, something in longer run. So this can be some fetal origin of adult disease. And then the future pregnancies, we know there is an future CS, chances of uterine rupture, placental problems, the adherent placenta, placenta accreta, which is coming up in such an important way that we are seeing that there is an increased incidence of adherent placentas. And it can also have stillbirth, preterm labors, and also even scar ectopic, and all these pregnancies are very high, cesarean scar ectopic. So we know that there are implications. We need to counsel and we need to optimize our cesarean section. So this is the study which is showing the balancing act, and this was a comparative study between the complications from vaginal delivery and the cesarean delivery. And when we check and compromise, you see the overall morbidity and mortality rate was little higher in cesarean delivery as compared to the vaginal delivery. And even the maternal mortality also was high, chances of amniotic fluid embolism was high. Though the perineal tear and lacerations, but the incidence is really less in the vaginal delivery. And this is very important as per se as the maternal thing. And in neonatal thing, the respiratory morbidity was higher in the cesarean group. So this is very important that we need to weigh the pros and cons of each mode of delivery. So common indications we know, or there are arrest of labor becomes the most commonest, that patient has not progressed. So we need to look into this indication, how we make the labor progress very well if we need to, in fact, optimize our rate of cesarean section. Second common being the non-reassuring fetal tracing, which I think Ameya mentioned in his talk about the continuous fetal monitoring versus the intermittent fetal monitoring. And that also was accepted very well if you keep an intermittent but a very closed watch on the fetal heart sounds. So this also can reduce the rate of unnecessary cesarean section for non-reassuring fetal heart. Multiple gestation, we know this is because of the IVF. So we need to actually not generalize all twins, but need to find out that if we can actually give a vaginal birth to this twin pregnancy, then malpresentation like breech, that the arc of delivery of breech is little fading. There is the common thing that if there is a breech delivery, at least the primary with breech, we are doing cesarean, but multi with breech, definitely the breech delivery or the breech, teach the breech delivery, which is going on everywhere. In fact, we had in Mumbai and also in the AICOG, Dr. Frank Loven coming, and he also spoke upon how to conduct workshops to teach the breech. So all these incidents also can come down, which are the major cause of cesarean section, and the other causes are little less, and we can actually cut short these causes so that our rate goes down. So now these are the newer indication which has come commonly: ultrasound showing an oligohydramnios, AFI being low, or a cord round neck, which is not an indication for cesarean section, not even the 2 loops of cord. Then patient coming with PPROM, PROM. If the patient has not gone in labor, and then we want the patient to deliver smoothly without any adequate trial, or an ART pregnancy, an absolute pregnancy, or cesarean on demand. All these are the newer indications, and we don't want any medico-legal problem coming into. And we really, some patient is like really not going good or not talking good, and we don't want any medical legal problem or anything. And some people also attribute towards getting financial thing like vitamin M or something. So all these newer indications are coming up very, very well. And this is a state-wise distribution. We see how we are ranking in the cesarean section. It is more higher in the south states of Telangana, and we can see the rates are actually high. This is by the NHFS survey, but I think the rates have become even more now if you actually go to those places. And in the private sector, the cesarean rates at some places are really high. I don't want to tell actual rates, but they are higher than what it is projected. We really want to do something, but what are our concerns? So there are concerns, are these maternal concerns. Fear, patient is fear of labor, and because many people, patients, they have a community where they come, they discuss about being in labor, and some neighbors being in doing cesarean section, and they may not have labor pains, and then patient comes with intolerance to labor pain, fear of labor pains. Then there can be misconception that genital damage may be more after vaginal birth. So this is very important. They feel that if I deliver vaginally, I may get genital damage. Misconception that cesarean section is safe for baby. Baby may be absolutely fine. There may be no asphyxia. So all these maternal issues, they come about, and they demand cesarean section at request. So we have these maternal issues, and when women who undergo cesarean section may not receive complete informed choice to make a right decision. So in fact, when there was a study done, 67 of the mothers were told the cause of undergoing a cesarean delivery. 40% were informed of positive information, and only 6% knew negative cities of cesarean operation. So when we talk to a patient, we say cesarean is absolutely safe. But I think our counseling for cesarean, if a patient comes with all cesarean, like with maternal issues, we need to counsel and tell these patients that yes, you are asking for cesarean, but it is not the same. We need to clear this misconception to our patient. So we need to inform them completely and not give them a picture that cesarean section is absolutely safe. Then coming to the most important is the medico-legal issues. We hear so many incidents of violence against doctors, at everywhere, even in urban cities as well as rural places, and certain litigations we hear in newspaper, we read articles of all that, the compensations, the judgment, the insurance. So all that is making people very fear, because we want a good outcome. We want to give a good maternal and fetal outcome. So that becomes the main goal of an obstetrician. And with this medical legal issues, you can be questioned about an unnecessary trial or failure to intervene or delay to intervene, all that. So that is one of the problems which we all are facing, and we need to even take into consideration some medical legal issues may turn up in future. And social factors that some patients will come, I want my baby to deliver on this day, on this time, some muhurat and all that. So these become the family, they have some religious or some astrology coming into picture, and they want to deliver at particular place at particular time. So these also are patients are seeing some muhurat and other things. Then coming to the health professionals. So what happens is that more and more deliveries now, as like Dr. Madhuri Madam also said, that private sectors also, there are many patients who are delivering. We are maintaining standards at the private sectors. So we want the private sector people to have the vaginal delivery, teach the art of vaginal delivery. In fact, this vaginal delivery art needs to be taught now to the people taking training in their undergraduate and in the postgraduate. They need to be told all the time in their medical curriculum that yes, there is an art of vaginal delivery. It is not a dying art or something. And I think this was very well covered in the episode on operative obstetrics. Dr. Piley came and he in fact told us how we can actually do a skillful vaginal delivery with forceps, with vacuum, and give a good outcome to our patients. So I think the workshops like what we conduct at Foxy level or at conferences and having talks will give confidence to our doctors, because we are all scared about the unnecessary tears, maybe the lacerations or the cervical tear, and then we want to do a safer way out. So the art of vaginal and the forceps delivery needs to be taught to everybody. Then CTG partogram needs to be maintained. So we actually can do cesarean section. I in fact went to Andhra Pradesh and many states for lecture, and they were worried about their alarming rates. So we never focused or emphasized to tell them that stop doing cesarean section, but at least maintain a partogram, plot a CTG, so that you yourself know the indications would be very evident when you have to show or you have to audit. You know why the patient was taken for cesarean section. So maintaining a partogram and documenting why the cesarean section was done is very important. And sometimes, patient goes in labor for days together. So it becomes really difficult to sit with that patient. And this is the point which everybody agrees, that people feel that the cesarean section is done by a doctor because the cost is more or doctor may charge more. But I feel vaginal delivery is more challenging. The doctor needs to sit all along with the patient during the entire labor, and that should be well compensated. So if that is well compensated, this intolerance to long-lasting deliveries will actually go away if doctor is compensated for the time and effort which we are putting in it. So, and with a VBAC or TOLAC, there is a fear of rupture uterus. Patient has delivered cesarean section, and we constantly feel this patient needs to be really needs to be monitored so closely. At every point, we are scared that if there is a rupture uterus, what will happen? If the patient progress is fine, it's good, but if she is not, and that makes that once a previous LSCS, we need to have a patient as a hospital delivery and need to see if it's a non-recurrent indication and everything falls good, we can actually give this patient a VBAC delivery. And also there are some colleagues I know, I actually, when this cesarean section came, there are certain people who are even surgeons, they can't do cesarean sections. So cesarean sections are done by surgeons. So this malpractice is there. Patient needs to get aware that they need to go to a proper gynac. We are so many at every part, and not to go to some surgeons which will do cesarean sections also. So this is very important as for the health professional is concerned. Then coming to knowing what is prolonged, that is a latent phase, it can extend from 20 hours in a primipara to 14 hours in a multipara. So these definitions needs to be really introspected and changed. And prolonged latent phase may be almost till 20 hours in primipara and 14 hours. So we can wait for this time. The patient actually goes into active labor. And also we can extend the first stage. You know, the first stage starts after 6 centimeters, ideally on a partograph you chart after 4 centimeters, but this can be after 6 centimeters. And this is by the Society of Fetal Medicine, who have come up with this new terminologies. And arrest of labor will be if there is a spontaneous labor more than or equal to 6 centimeter dilatation with membrane rupture, and one of the following, that is 4 hours or more of adequate contraction, or 6 hours or more or inadequate contraction and no cervical change. So this is when we call that the first stage of labor has been actually prolonged with or without contraction, and then we need to intervene in this first stage. And coming to the second stage, they've extended to almost till 3 hours in a primigravida. So before diagnosing arrest of labor, second stage, if the maternal and fetal condition permit, if everything looks okay, then at least 2 hours of pushing in multipara and 3 hours of pushing in nullipara should be allowed. And long duration may be appropriate because sometimes you use epidural analgesia or there is a fetal malposition, so that rotation may take time. So we need to just document, and if everything is okay, these are the terminologies which are coming in and we need to do it. Then management option to reduce cesarean section in the second stage. You can do what is called as manual rotation of the fetal occiput. This is very common, which was beautifully demonstrated by Dr. Piley in the video in episode 4. You can watch or undertake the operative vaginal delivery, where you can comparison of the forceps, vacuum, and everything can be done. So this is how the vacuum of forceps we need to revive, which I've already spoken. And this, Sir Ian Donald said, give me a pair of outlet forceps and a keel end forceps, and I will practice obstetrics in any part of the world. And this was the power of that forceps and vacuum. So I think we really need to take our forceps and keep that on our delivery trolley handy whenever it is a need arise. And I'm not going to go into detail of when to use and vacuum and forceps, but vacuum is definitely an instrument. You need to use your skill. You need to have your experience to use. And both the instruments are used when there is a full dilatation, regular contraction, engaged head, accurate diagnosis of fetal position, amniotic sac is ruptured and bladder needs to be empty. This is very, very important. And the indications, we know where when there is a failure to progress with insufficient contraction, or there is a fetal distress, we can give, and contraindication is there when there is a malposition presentations, head is not engaged, or very, very preterm baby will avoid. And forceps delivery, definitely forceps, apart from the cut shorting, the second stage, after coming ahead of the breech, we can apply forceps. And definitely when there is a transverse lie or a brow, you will avoid. And this is a paper which shows that towards safe practice in instrumental delivery, and this was a paper which shows that safe practice in instrumental delivery addresses various types of errors, and that may occur, and places a strong premium on the operative skills, competence, and familiarity with the instrument. So use whichever is familiar or you're well versed with. It's always better if you're good with the forceps, you apply. If you're good with vacuum, you can apply it routinely. But you can adopt a method, and if not, you can do training to improve the success rate. This is the manual rotation of fetal occiput. So if you feel it transpose, you can hold it between your thumb and other fingers, and you can rotate the occiput and bring it anterior. So this technique also is very, very important, and you need to know how to do this technique. This is what the Society of Fetal Medicine and ACOG guidelines, which I was talking about, of extending the latent phase and the cervical dilatation beyond 6 centimeters. And this is 1B strong recommendation with moderate quality evidence. But here we actually require more studies and more data on these recommendations. I know in India, we're waiting for more than 3 hours in a nulliparous, definitely it is going to cause an obstetrician distress, and we really need to have a good evidence if at all any problem occurs. So we are waiting for more amount of studies to come and recommend all these recommendations, and when they come, we can have more discussion on it. But if everything looks okay and reassuring, and if patient, we need to actually diagnose what is the first stage, second stage, so that we don't do unnecessary intervention in these stages. Coming to the fetal monitoring, also they have said that because we have lot of meconium stain like going for cesarean section. So even amnio infusion, if there is a variable fetal deceleration, have even reduced cesarean section rate with a strong recommendation and high quality evidence. But there are very less papers on this amnio infusion. So we really need more and more studies. If we have studies, we can actually give our own recommendations. So that is what is from ACOG and Society for Maternal and Fetal Medicine. Also, induction of labor. Like we induce labor, we need to not induce it very early, but 42 weeks is something which we need to wait if everything, all parameters look okay. And cervical ripening methods needs to be used in unfavorable cervix. So this is also a good quality of evidence. So induction of labor is really, really very important, and avoid early and unnecessary inductions. So other recommendations about fetal tracing we have spoken, and also continuous labor monitoring also we have spoken. Also the individual and organization should encourage research to provide better knowledge base so that we have our own studies, we can defend ourselves about all the policy changings about the lower rate of primary cesarean section. Coming to the labor management protocol, this is so important that we have our labor management protocols. We need to chart everything on cartograms. We need to augment labor. We need to use our drugs, oxytocin, everything very judiciously. And we need to chart everything and document everything. That is very important. So this is how the amniotomy, we can do it. Everybody is doing. And now touching upon the Robson's classification. So important, we recommend everybody, when the audit had come from the government, the family welfare department, they had said that you're supposed to have a self-audit with Robson's classification. And everybody should, in fact, the government is telling us to adopt this Robson's classification. So this is 10-point Robson classification, which was described by Michael Robson. And Michael Robson had come to Mumbai, and we have heard his talks also. And this is a paper which shows that the 10-point classification, this was a Nigerian studies, and cesarean section rate was high. If it is in the 5, 2, 10, and 3 groups. So that actually increases our cesarean sections. So this is the 5, 2, 3, that is a singleton pregnancy. If it is a singleton pregnancy in a nulli gravida or a multigravida in a previous LSCS, or a singleton pregnancy less than 36 weeks. And if you have patients in these categories, then definitely your cesarean section rates are going to go high, because these categories are not the absolute indication for cesarean sections. So we really need to have have our antennas or alarm ready if most of our patients are going into these categories. So you need to have your self-audit, need to sit and categorize which category your patient is falling after every cesarean section. And now touching upon even WHO, they also in their statement on cesarean section rate has proposed that Robson's classification system as a global standard for assessing, monitoring, and comparing cesarean section rates within healthcare facilities over time and between facilities. In order to assess healthcare facilities, we need to adopt this Robson's and WHO guidelines about its implementation, interpretation, and standardization. Everything needs to be done by Robson's. So this is how the Robson's classification, these are the wheels. You know, the organizational level, what are the factors which are going to be? That is the professional power relationship, the cultural, everything, all these factors are going to affect. Then the health professional factors, and then the women and the community factors. So it's not only going to be depending on the 10 factors, but all the factors are interlinked on all the organizational level, the health professional level, and the community, the women's level, all the 10 factors. And the wheel is so important about what patients, the choices they make, the clinical factors which are there. all will take into account the indications for doing cesarean sections. And this is again the safe prevention and primary prevention of the primary cesarean section by ACOG and Society of Maternal Fetal Medicine, and they have given directives. And these directives were that first admonishes against the cesarean section in the latent phase. So don't do in the latent phase. Specifically, a prolonged latent phase should not be an indication for cesarean section. Second directive 2 is in the conventional practice, it recommends that cesarean delivery, if a labor is progressive but slow, then if it's a protraction disorder, this instance is typically managed with observation and assessment of uterine activity and stimulation of contraction if required. So you really need to do something if the contractions are not being adequate. Third instruction addresses cervical dilatation threshold, which we just spoke, from 4 centimeters to 6 centimeters. And thus this threshold standards for active phase progress should be applied. And fourth stipulation notes cesarean delivery for active phase arrest should be reserved for women beyond 6 centimeters with rupture membranes who fail to progress despite 4 hours of adequate uterine activity or at least 6 hours of oxytocin administration with inadequate contraction and no cervical change. So I think these recommendations are coming up in a bigger way and we need to consider them. Also, there are so many papers actually all over which are showing the cesarean section reviews. This was when there was a midwife versus the specialist care. So they were recommending a midwife to be there. And also there was study about hospital, how we can study. We need to give our own studies, the incidence of cesarean section among multiparas and lowering our cesarean section. This is one of the paper in which the areas like fetal distress, phallopelvic disproportion, repeat cesarean section being the major indication for cesarean section. So I'll end with a take-home message. We need to really do case selection. We really need to know our indications very well. We really need to document it. Training for instrumental vaginal delivery, yes, everybody should be well versed with that subject. Self-audit with Robson's criteria as WHO, really, really very important. But in the end, I want to just end by saying that medical profession on its own cannot reverse this trend. And we really require joint efforts with government bodies, the healthcare insurance industry, the women groups. Really, we really require everybody to stop unnecessary cesarean section and enable our women and family to be confident that yes, whatever the doctor is telling them, whatever care we are giving is the most appropriate from them. That confidence our patients should have so that we don't face any litigation. We don't worry about giving a good outcome, a safe outcome to our patient. And on the other hand, we don't worry about any compromise or any litigation in any time in future. So I think we should be confident about what we do. And I would end with a quote by Mahatma Gandhi: "Be the change that you wish to see in the world." And we definitely, we should give a message to everybody that we all are with the efforts. We all are really aware about the rates. We all are trying to not talk about the absolute indications for cesarean section, but try to improve the rates of the cesarean section where we can actually do something, in our practices. And the rate should actually be calculated not from the all overall rate, because sometimes some patient with previous LSCS or previous 2 LSCS or 3 LSCS or some complications may become an absolute, even placenta percreta, these may be absolute indications. So if these cases are rising, our rate should not be calculated from the absolute indications like a CPD or or if a large fibroid or something, but the rate should be actually calculated in which patients we were going to give a trial of vaginal delivery and which we have taken for cesarean section. So I think there are newer things are coming into pipeline and we really have to work on that way. And I really want to work in that way, and I want you all to support my candidature for the post of Vice President of FOXI. I am your voice and I am your candidate. I request you to please vote and support. The elections are in the month of August, from 1st to 10th August, and it will be an e-voting. A personalized voting link will come to your mobile phone. So do cast your vote. It is your right. So please vote and cast your vote and support me. Thank you so much. Thank you all for your patient hearing.
Dr. Komal,
Yes,
your
sir.
talk was excellent. You really covered A to Z of everything. All benefits, what is the harm, everything. But from my angles, why the cesarean rates are increasing? Because from the public point of view, because the violence on the doctor, on the treating doctor, she doesn't know if she will be, alive or not. What will be harm to her body? And second thing, the lifestyle of our women of society. They are such a sedentary work. They don't want any physical work. So
Yes.
that is the very, very important aggravating factor for the cesarean infection. And third are the societal culture like litigation. That's a thick, it's okay that we can face later on. The first thing, important thing, the violence of the doctor.
Yes.
So that has to be, government has to check on that. Government
Yes.
only can check the rate of the cesarean by providing the protection to the doctor.
Yes, I think that is very important because if we are protected, we are safe, we can give more to our patients. If we live in fear, how can we give outcome?
How can we?
Yes, that is
And
very
all the
important.
best for your success in your endeavor. All my wishes to you.
Thank you so much, Tarini madam.
It was really
My all wishes to you, Komal, for your forthcoming election. All the best. And your talk was really mesmerizing. You always say that you speak so nicely. You have dealt all the point very well. And we should try our best to reduce cesarean section rate. Definitely, we have to look into this. And definitely, we will do it.
Yes, thank you so much.
Super excellent talk, Komal ma'am.
Thank
And
you.
really, it was very nice hearing and seeing you both. And really, all best wishes are on your way, and we all are with you.
Thank you so much.
Always.
Yes.
Dr. Komal,
Thank you.
Dr. Komal, I would like to congratulate you. It was a meticulous, everything you touched, nothing was left. It was beautifully said, and it is really difficult to reduce the section rate. But yes, you have started something which will create awareness. So thank you so much, and my best wishes for your elections.
Thank you so much. Thank you, the chairpersons. I think we all are doing our efforts, and we all are doing everybody is doing their best to give quality care to women. And we all are pillars of women's health, and we are taking it forward. And everybody is doing such good work. That is what I want to say. And this was all the summary of our problems, what we are going to face, how we can actually go ahead to reduce the rate, because there is people saying it becomes very easy that you reduce the rate, doctors are doing, but so many factors come into picture. And I think the government, the agency, that is the reason I ended with it is not on the healthcare profession, but it is on the government also, because there are so many factors which run into one thing, So if all that is taken care, and as Dr. Tarini also pointed very well, that if we are safe, if we feel very ensured and we feel safe and relaxed, we will definitely do our best. Everybody wants to deliver a patient vaginally. It's not, but the indications are coming. You work in a tertiary center, you will get one high-risk case after case. How are we going to do justice to that patient? So that all is also very important. And I think we will discuss in an organizational point, and we will come up with some solutions, and we will need inputs from everybody of you, and everybody will be the part of the team.
One more thing you had very nicely put, that normal labor should also be given the same respect as cesarean section. And the doctors also should be given at level, at par the prices for that, compensation for it. It's because you put more effort in while you are laboring normal labor. You sit with that patient, you are taking care of that patient. So that message also should go.
Yes.
Dr. Ragini, that we can set our charges. For the last 15 years, I'm taking the equal charge for cesarean and normal.
Now I think we should take more.
That's nice. Yeah.
So I left now normal delivery, but I'm taking the same charges. Whenever a patient comes, labor charges, normal charges are more than the cesarean. So they cannot say we are doing because of the M vitamin. That is, money is always this thing is involved in the cesarean section. So M vitamins is no more there. If you see it, charges are the same for both.
We were in AMOMS last weekend, and we heard our president of AMOMS, Dr. Rajendra Pardesi. Interesting to hear from him. And he said that we should tell our patients that there are only two routes of delivery. One is vaginal and one is abdominal. There is nothing normal. Both are normal. There is nothing that vaginal is normal and cesarean is abnormal. So you have to tell your patients that what we are doing is a vaginal route or an abdominal route. And both are supposed to be the way what the patient is delivering. So it was a very important message which was given to all the members who were present in the hall at the time of inauguration. Dr. Rishikesh Pai was also there as a chief guest, and I was also there representing Foxy. So Mumbai Obstetric Gynec Society also got the Best Society Award out of the 46 societies which Maharashtra has. So it was really, concerned by the All Maharashtra Obstetric Gynec Society also regarding this intervention. And we all should be united in this issues about cesarean sections, about hysterectomies, And I want to add here one more thing that in Sion Hospital, we have started since we heard the lecture, the oration of Dr. Frank Loven. So we have started delivering breech presentations vaginally where the patient is on a forelimbs. And I cannot show the video right now, but we are going to take an ethical committee permission and do a trial where Mumbai will be the center for training of trainers and further training of students who are there, where we have delivered up to 3.2 kg patients vaginally breech, even footling breeches, and even third gravida. It's a very easy way. The patient can deliver absolutely fine, and uh, it's a really a great change, game changer for all those patients. Where over a period of time, if you train our residents or the further training modules are there for apart from forceps and vacuum incidences, even Arun Kumaran and other team from RCOG have said that we can continue and train them with forceps and vacuum. And this we add the breech delivery on forelimbs. This was done in 1950s and 60s, but over a period of time, Dr. Frank Loven said that we lost it, and then we started delivering breech with in supine position where the woman was on her back, and then we continued to deliver her with Morris's Smiley's West maneuver and further, all those things which we are training the residents. But this is a very important that all of us should go back now and train ourselves, even though we are consultants or even though we are above 50. Education doesn't stop, the knowledge doesn't stop, and something this can be, practiced. Of course, we need to take a proper consent, explain them about the issues of on four-limb delivery, and with all these things, facilities, and the proper training, this is a very good thing which you can change over a period of next 5 years.
Dr. Archana Verma madam is there. She wants to talk. Madam Archana ji.
Just put a I was listening to how can I go? I was so late in joining, so I have to be present till end.
Yes, madam. So thank you so much.
Hello, ma'am. Wonderful, very impressive. Komal, I must say, very, very impressive, and really, you are my all-time favorite, and giving, a lecture also, and as a friend also, and as a leader also. So my number one.
Thank you, madam. Thank you so much. Honored.
Hello, ma'am.
Hello.
Hello. So So I'll tell Dinesh to formally give the vote of thanks.
So thank you, ma'am, for such a wonderful lecture. I must say that being their student, I always believe that we have a two pair of parents. One is a biological parents who told me how to work, and these academic parents, Komal ma'am and Niranjan sir, they taught me the ethical path, the practical path, the patient-safe path for the field of obstetrics and gynecology. So thank you for being always supportive mentor for us. And thank you all wonderful ladies for your enthusiasm and participation. And definitely be budding obstetrician, definitely do something better in tomorrow with your guidance. So I must say that with this Q series, Q stands for question, and today's event is an answer for present and solution for future. So let's together treat her with dignity, with safe and care approach for the safe motherhood. So thanks a lot for being with us, and thank you all.
Thank you.
You are lucky, Dr. Dinesh, to have two